We now move to item number 8, Social Services. Receive program update presentation from the In-Home Supportive Services Public Authority.
Good morning, Chairman, members of the board, Sanja Bugay, Department of Social Services and Public Authority. And we're going to get started. So I do want to inform you that we have a correction on the PowerPoint for the slides 19 and 20. We have a one number corrected, and we've added a slide 21 and 22 since the materials were published. And there's some copies in the back and new materials that are being distributed. It's not. Okay, is it going to show up? Oops. Oh, there we go. Okay. So this is an update on our In-Home Supportive Services Public Authority. Wanted to kind of give you a couple of brief overviews. One, Public Authority is the employer of record for our in-home supportive services providers and is a local agency legally separate from the county. We have an ordinance that essentially created a public authority, which is a county ordinance 2.80.030. And our Board of Supervisors is essentially a Fresno County Board of Directors for our public authority. The public authority, so one thing that I really want to make sure that I'm clear about is the public authority is the employer of record for the purposes of bargaining and for purposes of negotiations. However, the IHSS recipient is the employer for each IHSS provider. So it's the IHSS recipient that essentially hires, trains, supervises, and fires the individual that works for them. So that distinction, the employer of record versus the employer, is important in this program. Just to give you a little bit of current caseload demographics for our IHSS program. So a snapshot of June, we had 24,000 or just over 24,000 active cases. We have about average 122 hours per recipient and 22,290 active providers in any given month. We had just under 3.3 million worked hours or paid hours in June, and about 70% of our recipients receive services from a family member. We've had a significant growth in this program over the past 5 years, and it has been a growing trend. We're not the only county experiencing this. This has been kind of experienced across the state. 32% increase in the last couple of years, about 9% increase in our average hours. So month of June, 3.2 million hours, but we averaged just under 3.1 million in fiscal year 23-24. So kind of to give you a sense, so from the public authority perspective, where we are with our MOU for IHSS providers. Our last MOU was from January of 2020, and it expired in December 31 of 2022. We started renegotiations just around September of 2022, and what our current terms is our current wage is minimum wage. We have a wage supplement that's on top of the minimum wage, that's 60 cents, and we have a health benefit rate of 85 cents per paid hour. So how this payment works for health benefits is we average the actuals for 3 preceding months and multiply it by 85 cents, and for every paid hour in any given month, we contribute 85 cents. We post updates on our negotiations on the IHSS or Public Authority website, and the link is actually on our PowerPoint. So updated terms and where we are in negotiations are publicly posted. I'm going to give you a perspective where we've been with our IHSS wages and benefits. So prior to the last MOU, we were paying a minimum wage. We did not have a wage supplement, and we were contributing 85 cents for benefits. So per hour, we were spending $12.85. With the MOU, the 60-cent supplement started, but the minimum wage also went up on the same day by $1. And minimum wage has been increasing by $1 in 2019, 2020, 2021, and 2022. The last 2 years, it has been a 50-cent minimum wage increase. So when you look at it from the prior MOU to now, we've realized a 33% increase in wages due to minimum wage, overall 38% increase in wages with the minimum wage and a supplement, and overall 36% per hour cost increase in the program. So I want to spend a little bit of time on health benefits and how they work, because that seems to be where a lot of questions are coming up from. So our county health benefit is paid 85 cents per paid hour. Average cost in the recent months has been just over $2.7 million a month. So we spend just under $32 million a year for health benefits. That is the county contribution to a health trust. The county does not control who gets covered. We do not select the coverage. The health insurance is administered by Dublin Insurance, which is selected by our union representatives, SEIU Local 2015. Currently, they're using Kaiser Permanente traditional HMO plan, which costs about $1,416 per month, or $16,000. The eligibility for health benefits and who actually gets covered is not determined by the county. But what we do know is the cost of the health insurance, how much we contribute, and currently of our enrolled providers. So we have on our registry just over 25,000 providers. 2,000 providers currently, or about 8%, actually get health coverage. So I want to share with you overall health coverage breakdown, and I want to distinguish that this is what health coverage looks like right now, not who is eligible for health coverage. So of our 25,000 registered providers, 2,000, or 8%, are covered by SEIU by the health insurance. 8,959 providers have coverage other than what we're aware about. So they're either covered through their own personal health insurance or Covered California. And 56% of the providers are currently receiving Medi-Cal. It is possible that additional people are actually qualified for Medi-Cal. This is who just receives it currently. I do want to spend a little bit of time on Medi-Cal because there's just a lot of misunderstanding about Medi-Cal. Medi-Cal in Fresno County is actually done through managed care. We have 3 managed care providers starting in January of this year. Anthem Blue Cross, Calviva, and Kaiser was added this year as an option for managed care for Medi-Cal. There's also been expansion of Medi-Cal for past several years, including January of the current year. So significant expansions that matter is that asset limits for Medi-Cal eligibility were eliminated in January, which means people who previously, based on income, qualified but didn't based on assets they have, homes, vehicles, those kind of things. That went away. There was also expansion of Medi-Cal for undocumented individuals aged 29 to 49, and then property limits were removed. These were significant changes that happened in January, that people who previously potentially wouldn't have qualified now qualify for Medi-Cal. The other piece that's significant for our IHSS providers is the IHSS provider income does not count towards Medi-Cal eligibility income if they live with their recipient. And 57% of our providers live with their recipients. So that income that's earned based on IHSS wouldn't count for eligibility, and that's for eligibility to Medi-Cal. That's significant. In addition to that, other than qualifying for Medi-Cal through Covered California, low-income individuals, up to 400% of federal poverty level could qualify for advanced premium tax credits and share of costs reductions when it comes to eligibility for health coverage. So statewide availability for health coverage, either through Medi-Cal or through Covered California, is significant in our state, and it is one of the programs that DSS administers. I want to talk to you about county share of cost when it comes to IHSS program. So our county share of cost is referred to as maintenance of effort a lot because it is how it's defined in realignment legislation. It was reset and rebased in fiscal year 1920. So in that year, our county share of cost was $43.5 million. However, that was the starting point. Each year, our county share of cost grows. So what's budgeted for fiscal year 24-25 is $56.5 million. Our MOE base increases two different ways. First one is on an annual basis, we have a statutory 4% increase. And that pays for minimum wage increases and increases in growth, hours growth. So if you remember from earlier slides, we've been increasing 9% every year. That increase in hours and minimum wage increases, the county contribution to that is this 4%, which for us is about $2 million a year. So no matter what we do, $2 million a year is a county share of cost increase for IHSS. There's also a secondary way our cost can increase, which is if we have locally negotiated wages and benefits, and that share of cost isn't at 4%, that's different. So I want to go over that a little bit. So county share of cost, the MOE, the state rebased it and kind of set it as a county statutory increase or county statutory share of cost, which is a good deal for the counties, the MOE structure. The 4% pays for the increases in costs that you, quite frankly, have no control over. That's the 4%. The costs that you have some control over, the state sharing ratios are 16% for the county, about 30% for the state, and 53% for the federal share of cost. The reason these percentages look different is it really depends on the type of case in IHSS, but these have been our averages for the past several years. So any cost increase that is locally negotiated increases our MOE by this 16.2% share of cost. State actually limits its own contributions to locally negotiated increases. So in statute, state limits their costs to minimum wage plus $1.10, but gives counties an option for 2-3 year periods when they can increase additional 10%. And there's some complicated language, but essentially the state caps their ability to participate in the cost by giving us just $1.10 above minimum wage, and then 2 times we can exceed it by additional 10%. Fresno County currently pays $1.45 above minimum wage for our 85 cents in health benefits and 60 cents in supplement, and we are using one of those 2-3 year periods with state approval in order to get their participation in our costs. So I want to kind of show you the last few years of what has happened with our county share costs for this program. First item is fiscal year 1920, our $43 million. And at that point in time, our monthly wages and benefits were $13.85. As the cost grows for minimum wage, our MOE, other than the fiscal year 2021, when the 60 cents and minimum wage increased, so the increase in MOE was 11%. After that, every year, our costs have been increasing by additional $2 million, or about 4% a year. So in the years where we have any locally negotiated wages and benefits, our MOE would grow by whatever that calculation is. And then subsequent, that MOE grows 4% a year. So what we have budgeted, so you see the trajectory from the $43.5 million to $56.5 million. However, that only reflects a fraction of the IHSS cost. So the total IHSS cost, and I have both 23-24 and 24-25 for you, actually includes costs that are not reflected in our county budget, because we're only budget county share of costs and then a state and federal share of health benefits. But the full cost of the program is all the hourly wages, including overtime, our payroll taxes, and health benefits. So the total cost of our program is actually in 23-24 was $732 million, and the county share of that was $54 million. That covers our 3 million hours a month or 37 million hours annually. what that looks like in fiscal year 24-25. And these are now projected numbers because we won't have actuals. We barely started the year. We are anticipating to average 3.4 million hours a month, or 41 million hours annually that are paid, for projected wages, benefits, payroll taxes, and a minimum wage increase that's happening again in January. Projected costs are $852 million, and our MOE at this point in time is $56.5 million. I wanted to share with you how that's reflected in the overall DSS budget, and I know the slide is busy, but I'm going to spend a little bit of time on it. County budget for Department of Social Services is just over $1 billion. We have two programs that have dollars that are transacted, administered by my staff. We do all the work. However, they're not reflected in our PeopleSoft and therefore not reflected in the county budget. The first item for that is our food stamp benefits. We issue in our county $564 million in food stamp benefits. We also issue $761 million in state and federal wages for IHSS providers. So the total budget, the total economic impact of DSS is really $2.3 billion. It's just that $1.3 billion of it isn't reflected in our PeopleSoft and therefore not reflected in our budget. So when you look at our entirety of our budget, it really should be $2.3 billion. And of that, $852 million is IHSS. IHSS reflects just under 37% of DSS budget. The county share of that, so we get 9091 realignment and net county costs to cover county share of cost. 9091 realignment is the only funding that we get from the state that's a little bit automatic. It's not really linked to our costs. It's not linked to our spending. It's linked to our sales tax and VLF. This was a legislation that was passed in 91, and the number of human services programs, IHSS included, were realigned. That realignment that we receive is budgeted at $91 million. When realignment is not sufficient or the program is not realigned, county uses net county cost. The net county cost in our budget is $32.4 million. So total county share of cost for our programs out of this $2.3 billion is almost $124 million. Of that, IHSS county share of cost is $56.4 million, our MOE. That reflects over 45% of our net county cost. So in our department, IHSS program is about 37% worth of total costs, but 45% of our county share of cost. It is the largest program financially that we have in our department. I do want to spend a little bit of time on realignment because it is the only funding source that we really have for increases in costs, and it is a funding source that's economy dependent. So sales tax and VLF, when they do not perform, our obligation to cover the cost is still there, but the revenue isn't necessarily. Our sales tax and VLF, our base revenue, is at $83.7 million for upcoming year. And I want to remind you that in our department, we budgeted $91 million. The difference is that we had some carryover funds, fund balance, that has been reducing every single year. So we're reliant on that fund balance to basically balance the budget. So from my perspective, given that our costs are ongoing, it is really concerning that our ongoing costs are $91 million and growing, and that our ongoing revenue is $84 million. But other than DSS, the only other program that receives social services realignment is California Children's Services Program in Public Health. They take about $1.6 million. The rest is in DSS, and majority of it we budget for our IHSS program. And I have just a couple more slides for you to give you the context of the IHSS in the county budget. So the pieces that are budgeted for 23-24, we have a $4.8 billion county budget and $87 million that's budgeted in IHSS. What that really looks like when you count off budget amounts, which I do think is a more relevant number, the county budget, if everything was budgeted for IHSS, would be $5.5 billion, and $778 million of that would have been IHSS program, or 14% of the total county budget. It would take up 2% of the county share of cost. And what that would, the added slides of what that would look like for fiscal year 24-25, the county budget, if the state and federal share were budgeted, would be just under $6 billion. And the IHSS program would be that $852 million. IHSS is it remained the same, at 14% of the county budget and 2% of the net county cost. And what net county cost reflects is really any revenues coming in for countywide revenues plus any fund balance. And IHSS program, given that we're growing each year, would take up 2% of it. So that concludes my presentation, and certainly I'm here to answer any questions.
All right, any questions for staff? A couple of quick observations on this. So again, I appreciate you pointing out that the IHSS program here at the county is the largest single program that we have by far. I want to say the sheriff's budget for 23-24 was around $360 million. Anyone here, Paige? I think it's about right around there, $350 million. So this IHSS program alone is almost 2.5 times the size of the entire sheriff's budget. So a lot of people who are in need. What does concern me is how quickly that program is expanding. And also, too, if the state or federal government walk away from their commitments to us, because of the size of this program, I don't know how the county would be able to pick up, to shoulder even 1% or 2% change where we would have to pick up more of that burden. Because we're approaching $1 billion enterprise. So a lot of money goes into that program. I think you said 25,000 plus providers here in Fresno County. And when you take a look at projections over the course of the next 10 years, do the projections show that this program is going to continue to grow or stabilize at some point? What do your projections show?
It is really hard to tell. It has been growing every single year. It is our program with the largest amount of growth. And part of where the MOE construct is really important for the counties is your capacity to limit the growth of the program is basically non-existent because it is dependent on Medi-Cal expansion. So Medi-Cal expansion expanded IHSS as well. It prevents out-of-home placement for individuals who are disabled or individuals who are elderly. It is an incredibly important program. It is, however, incredibly expensive. Our growth has been increasing at an increasing rate. Part of that last few years has been expansion of Medi-Cal, and last expansion of Medi-Cal happened in January of this year. So we were actually projecting that for this, even though we realized 9% increase this past year, that we're really looking at an 11% increase in this upcoming year. That's what our projections show. I don't know where the state is heading with the expansion of Medi-Cal, but part of the importance of the county share cost is really critical, is because the eligibility for the programs and program structure is statewide driven or federally driven. Our county share of cost capacity to maintain it, even at the current structure, is questionable.
And then looking at the county's share of any increases, I think you said the county needs to pay 16%, states at about 30%, feds are 50 plus percent of cost. But are there limits even to that, where if we were to give like wage increases where we have to assume more than 16% of cost? And even that is astronomical when you're dealing with 41 million hours and 25,000 plus employees. You're talking millions of dollars a year, if not tens of millions of dollars a year, potentially of cost.
Yeah. So federal government and state government limits their own costs. So we cannot pick any wage we want. Feds will have their limit to the contribution based on twice the minimum wage. State government actually in the realignment statute limited their cost to this $1.10 above minimum wage. They they said we're going to make 2 3-year exceptions. So realignment legislation can change. It has changed over the years. But at the moment, what's in statute, that they're going to participate at this 30% rate, as long as feds participate, up to $1.10 above minimum wage. They gave counties an ability to negotiate for more than that, and they will still participate up to 10% above that number, right? We are actually exercising one of those options because we are at $1.45. We're at $1.45 above minimum wage. So we've exceeded that $1.10, and we've utilized one of those 3-year periods to pay more than minimum wage.
So if we choose to go higher, do we assume 100% of the cost then at that point?
We assume the state share of costs. So our cost would be, feds would still participate. We would assume actually
46%
yes,
of the cost,
as opposed
basically.
to 16%. Yes.
Okay, which still is almost 50% of whatever that excess is.
So just to kind of give you some numbers, $1 cost increase, the county share of cost at the current sharing ratios is $5.8 million, a little over. So think of it as $6 million for $1, right? If past a certain point, the cost would be significantly more because $6 million represents 16%. You'd have to triple that. Right?
Triple it.
Yeah.
All right, thank you. This makes sense to me in my head, so I appreciate the exercise. Any other comments? This is a general presentation. There's no action that we're taking, but I appreciate the department being here today to bring us up to speed. Any legislation or anything like that that are causing pause or concern for the IHSS program, or does everything look like it's going to continue to operate as it has in the past, at least for the next 12 months?
At the moment, there's nothing concerning. The program continues to operate. Medi-Cal expansion will increase our hours, but other than that, it's a program as it is.
All right, thank you very much.